Hi everybody, my name is Nicola Maurizzi. I'm a cardiologist from Lausanne University Hospital. I'm very passionate about cardiomyopathies, and I'd like to welcome you to the fifth episode of HCM Pills. We are very lucky today because we have Professor Connie Bezzina from the Amsterdam University Medical Centre, who is a true pioneer in the understanding of the genetic basis of inherited cardiac disease. So not only cardiomyopathies, but also ion channel disease such as long QT syndrome and many others. So I'd like to remember you that this series of podcasts is sponsored by the European HCM Patient Association, a non-profit organization aimed at improving the understanding and the awareness of this disease throughout all European countries. So Connie, thank you for being here with us. So let's start from a very basic things. How would you explain the genetics of hypertrophic cardiomyopathy? Hypertrophic cardiomyopathy is the most common genetic heart disease, and how would you explain this?
Hypertrophic cardiomyopathy has a heritable component, that is, it runs in families. In about half of patients, we identify a genetic change, which we classically call a mutation. We see that oftentimes hypertrophic cardiomyopathy is inherited in an autosomal dominant fashion. That is, the mutation is inherited from one of the parents, and there is a 50% chance of it being passed on to the next generation. In hypertrophic cardiomyopathy, mutations occur primarily in genes that code for proteins that make the sarcomeres, which are the contractile units of the heart. And of these proteins, of these genes, mutations also primarily occur in two specific genes more often.
Okay, so it's very clear. Something that is meant to, the instruction to create the sarcomere, which is the engine of the cell of the heart. You get a mutation, something that is not written well, and you ended up having a disease. So why it is important to propose a genetic testing to a patient with hypertrophic cardiomyopathy? What are the benefits?
Yes. So for hypertrophic cardiomyopathy, there are two major benefits. One of them is to confirm the diagnosis. This is important because it helps the clinician differentiate hypertrophic cardiomyopathy from other clinical conditions that are also associated with a thickened heart, such as hypertensive cardiomyopathy. Another very important reason is that once we identify the familial mutation, we have the opportunity to do predictive genetic testing, meaning that once we've identified the mutation, we can test the relatives for the presence of the mutation. If we do not identify the mutation in the relative, that person can be discharged and can be largely reassured. The risk of developing hypertrophic cardiomyopathy by that individual is similar to the general population. But on the other hand, a relative in whom we identify the mutation, that person will need to be seen clinically at regular intervals.
So, very nice. I have hypertrophic cardiomyopathy, I do a gene testing, and I get a positive result. That is to say, I have a mutation.
Yes.
Are there any good and bad mutations? So the response and the gene in which I have the mutation, are there any difference in that? And are we able to predict my disease evolution with respect to the mutation?
Yes. So, of course, we're very interested to find those relationships because we want to offer, as personalized therapy as possible. We want to find those individuals who are more at risk than others. And actually, research on this has been done, and some tendencies have been reported of mutations in particular genes being associated with maybe more thickened heart, or more severe symptoms. However, what's very important to realize is that within families and across families, we observe a lot of variability for mutations within the same gene. So also within a family, individuals who carry the same mutation can have a very different disease severity. And essentially, this variability hinders, the clinical actionability of those reported differences.
That sounds really, really important. So we spoke a lot about families. You already, proved that screening a family harbors direct clinical consequences to diagnose or to reassure patients that are not diseased. So is there a good timing to do that? And this also relates, I have children, when shall I start testing them?
Yes. So essentially, the age of testing relates to when we expect the disease to develop. So we know that, of course, there are cases where hypertrophic cardiomyopathy presents in childhood, but typically hypertrophic cardiomyopathy presents from adolescence into middle age. So essentially, knowing that genetic testing should be done from around the age of 10. And if you are dealing with a particular family where the disease is presenting earlier, you can, of course, adjust the age of genetic testing to a younger age accordingly. But typically, it's from around 10 years of age.
That's very important, Klingemes, because there is a lot of confusion about that
Yes.
all over Europe. So still, let's insist about these families. As you said, there are families in which we do have probably the same gene that is mutated, and the son do not develop the disease up to age 60. The other, his sister, do develop the disease at the age 20. Why there is such a great variability, and have we understood that so far or not?
So that is a very active area of research, and actually one area of research where we're very interested in. So basically this in genetic terminology is called reduced disease penetrance and variable disease expression. There are different factors that can contribute to this. One aspect is the fact, and actually this is something which we have shown in recent years, is that together with the familial mutation, there is co-inheritance of additional genetic factors that modulate the effect of the familial mutation. Now, these additional genetic factors, which we call polymorphisms, have individually a very small effect, but they can have a substantial effect when you consider them in aggregate. So essentially, you could have a mutation carrier who has a high burden of these polymorphisms, who goes on to develop disease and maybe severe disease. But within the same family, you could have another family member who has the same mutation but has a lesser burden. So he's kind of protected, will not develop disease, or if develops disease, will have less severe disease. As I said, it's a very active area of research. We started to slowly start understanding about these genetic factors, but it's not only genetic factors. We also know that there are other non-genetic comorbidities or environmental factors, such as hypertension, such as obesity, that have been established or are emerging as important predictors of disease expression in mutation carriers.
These are super interesting, because if you have to picture this in our mind, we do have like a threshold that is disease. Let's say that mutation accounts up to a certain level. So this additional gap is really filled by these other factors that we are starting to identify, mostly thanks to your research, that this additional step. And this is also true for people who have the disease already and who have a severe disease. So this also probably contributes to the severity, so how hard the disease is or not.
Yeah, so essentially we call it a susceptibility threshold model. So we think that the mutation gives you a push towards that threshold, and then you, by the burden attributed by these additional genetic factors, the polymorphisms, they make you reach the threshold and determine the susceptibility, the severity, as you mentioned. Yeah.
And this brings me to my next question, because I think the answer lies there. I do take a test, a genetic test. I have hypertrophic cardiomyopathy, and they tell me it's negative. They don't find any mutation. Does the answer lies still in this theory? It is not more any theory, but in this data about the polymorphism?
Yeah, so as I said in the beginning, in half of patients, we do not find a mutation. And what we have shown actually is that those polymorphisms that are modulating the disease in the families with a mutation actually also contribute to the disease in patients who do not have the mutation. And actually, we think also they actually probably play a more prominent role. We see a higher burden of these polymorphisms in mutation-negative individuals. So in these mutation-negative individuals, it's really the aggregation of these additional genetic factors that is really pushing them to reach the threshold for the disease.
How far are we to put all these in clinics? Because this is very important to explain to our patients that have a genetic negative testing and do have the disease. So how far are we from going into clinic?
Yeah, so these studies have started a few years ago, and as scientists, we're always very careful. Basically, I think we need to identify more of these factors to be able to determine more of the susceptibility and more of the variability. What we think is that probably the first place that we can start applying this new knowledge in the form of polygenic risk scores, where we really count the effect of these variants together in the form of a score. As I said, each of them has a small effect, but together they have a large effect. So this is where the field is. Counting these variants together and then testing that score and seeing, can we use that score to predict who will develop disease, to use that score to predict who will develop severe disease. But we also need to understand is that, it's not only these additional genetic factors, it's a myriad of other factors. And we need to start developing risk prediction tools that are multimodal.
Yeah.
So considering the genetic component, but considering age, sex, comorbidities, all those factors. So we need to dissect all these factors and come up with prediction models that take them all into account.
That is super interesting, and thank you very much for this insight. So I believe genetic technology has evolved dramatically over the years. So when you do a genetic testing for cardiomyopathies, how many genes do you test, and with which technology?
Yes.
What do you use?
Yes. So essentially, when I started genetics, we're testing gene by gene. Now, indeed, we test in DNA diagnostics, which we test panels of genes. Importantly, we test the genes that have been robustly associated with the disease. In the general population, we all have genetic variation. And actually, rare genetic variation that causes these diseases is collectively very common. So when you identify a genetic variant in a gene, one challenge is to really determine, is this really the causal mutation in the patient? That is at the moment one of the most difficult things we're still dealing with. It's difficult sometimes when you do find a rare genetic variant, which is a good candidate to be the causal variant in the family, to really know, is this really the causal variant in the family? That is one of our ongoing challenges. But indeed, in the last 20, 30 years, the technology has improved enormously. So, besides that challenge that I just mentioned, we can do very accurate genetic testing, very fast and at much lower costs than before. And what I think is, the DNA diagnostics labs, are more and more deploying, whole genome sequencing, so even beyond the panels, or doing virtual panels. So basically, they would do DNA diagnostics by means of whole genome sequencing, and then within the whole genome sequencing, really look at the well-established genes and look in those well-established genes, is there possibly the mutation lying there? The advantage of moving to whole genome sequencing is that it gives us the opportunity to look at places in the gene that we're not currently looking regularly in. At the moment, we're looking at the coding region, which is the part of the gene which really codes for the protein, which are those sarcomers. But we have also other places in the gene where we're not probably looking sufficiently at the moment, which are not coding for the building block, but are coding for the amount of protein that is made. And I think that in the coming years, as more labs use to whole genome sequencing and move to whole genome sequencing, and as our knowledge of the parts of the non-coding genome increases, I think we might increase a little bit also the diagnostic yield, because we'll be able to find mutations that are simply hiding in places we're not yet looking for.
That's extremely interesting. So go to see the dark region, we'll put some
Yes,
light
yes.
also in our question
Yeah, and
box.
also moving forward, as we hopefully, develop some clinical applicability of those polygenic risk scores, then in one test we'll have the mutations and the polygenic risk scores in one place, in one test. But yeah, that is for the future.
Yeah, that's so exciting. So, and genetics is also a diagnostic tool, predictive, but can also be the object of a therapy. Can we modulate somehow genetics in that sense?
Yes, this is another area of intense research. Of course, once we find a mutation, we found the root cause of disease. And if we manage to correct that, yeah, that could be a cure. So in its simplest form at the moment, gene therapy is basically gene replacement therapy, where you would bring in a gene where the gene is either faulty or the gene is absent. So, and also, we know there are gene therapy is being applied in other diseases already. So it feels quite close, but yeah, it's not without challenges. And the challenge is, to bring the gene product to the cardiomyocyte, to the heart cell. At the moment, yeah, the only way of doing that is by viral vectors. And yeah, that has associated challenges. But there's a lot of work, and there are very early clinical trials that are ongoing for hypertrophic cardiomyopathy. But yeah, thinking more into the future, once we know the exact genetic change, we could think of gene editing approaches where, you can change the letter in the DNA back to the wild type, to the normal letter. And that would really be a cure. But yeah, for all these approaches, it's a matter of getting the right efficiency and having the right safety. And yeah, it's an area where still a lot of research has to be done.
So thank you very much, Connie. It is super interesting discussing with you and knowing all those, future concepts that really applies to our clinical practice and explain a lot of question marks we do have in everyday life. So I thank you very much for listening to us today. Remember to subscribe to our channels and to comment to really give us your questions that can be objects of a future podcast and webcast. Thank you very much.
Thank you.